Hi, this is Dr. Ruby, and welcome to the second part of the lecture for Module 3. Today we will discuss the joints of the upper extremity. The major purpose of the upper extremity is to place the hand in desired positions and move the hand as necessary to perform required tasks. Here are the objectives for this chapter. Remember that you're going to use these objectives to assist you in studying for the quiz. These will be the things that I want you to learn in this chapter and in this lecture. This chapter concludes our study of the regional approach to the structure and function of the joints of the body. The joints that we will discuss are the ShoulderJoint Complex, the Glenohumeral Joint, Scapulocostal Joint, Sternoclavicular Joint, Acromioclavicular Joint, Elbow Joint Complex, Elbow Joint, the Radioulnar Joints. We will be skipping the wrist complex and the hand joints for time's sake. Most every movement of the arm at the glenohumeral joint requires a coupled movement of the shoulder girdle. This area is called the shoulder girdle, but possibly the term shoulder corset would be a better term. Although the scapula and clavicles along with the manubrium of the sternum encircle the upper trunk and act as a stable base-like girdle, the two scapula do not articulate with each other. The muscles that attach the scapula to the spine are similar to the lacing of a corset, so the term shoulder corset might be more appropriate. The term shoulder joint complex is a better term to employ when describing motion of the shoulder because most movement patterns of the shoulder require motion to occur at a number of these joints. The sternoclavicular joint may be looked at as the master joint because motion of the clavicle at the SC joint results in motion of the scapula at the Scapulocostal Joint. Augmentation also occurs at the Acromioclavicular Joint. Here are the average ranges of motion for the shoulder joint complex. Pure adduction of the arm at the shoulder joint from an anatomic position is blocked because of the presence of the trunk. If the arm is first flexed or extended, further adduction is possible, anterior or posterior to the trunk. The coupling of the shoulder girdle, the movement of the arm and the shoulder, is called Scapulohumeral Rhythm because motion of the clavicle is also required. A better term might be Scapulohumeral Rhythm. Generally, the term shoulder joint refers to the glenohumeral joint. This figure shows flexion of the arm at the shoulder joint, and figure B shows extension of the arm at the shoulder joint. The glenohumeral joint allows abduction and adduction in the frontal plane around an anterior-posterior axis. Lateral rotation and medial rotation of the arm at the shoulder joint take place in the transverse plane. The glenohumeral joint is located between the glenoid fossa of the scapula and the head of the humerus. In addition to the major functions we described, the scapula can move at the glenohumeral joint relative to the humerus if the arm is fixed. Reverse actions of the scapula that can occur at the glenohumeral joint are upward rotation and downward rotation. Pure adduction from an anatomic position is blocked because of the presence of the trunk. However, further adduction is possible anterior or posterior to the trunk if the arm is first flexed or extended. Because the majority of the stability that the glenohumeral joint has is derived from musculature, the glenohumeral joint is often referred to as a muscular joint. These are the average ranges of motion at the glenohumeral joint. The fibrous joint capsule of the glenohumeral joint is extremely lax and permits a great deal of motion. The coracomial ligament is involved with the glenohumeral joint. The glenohumeral joint's closed pack position or most stable position is lateral rotation and abduction. These ligaments stabilize the right shoulder joint complex. The superior, middle, and inferior glenohumeral ligaments are thickenings of the glenohumeral joint capsule. The coracohumeral ligament runs from the coracoid process of the scapula to the greater tubercle of the humerus. The coracoclavicular ligament runs from the coracoid process to the lateral clavicle. The coracoacromial ligament runs from the coracoid process to the acromion process. And the acromioclavicular ligament runs from the acromion process to the lateral clavicle. This photo shows the glenoid labrum, which is a rim of cartilage surrounding the glenoid fossa of the scapula. The function of the glenoid labrum is to deepen the glenoid fossa and cushion the glenohumeral joint. The subacromial bursa is shown in this picture between the acromion process of the scapula and the rotator cuff tendon of the supraspinatus muscle. This bursa's role is to reduce friction between the rotator cuff tendon inferiorly and the deltoid muscle superiorly. Rotator cuff tendinitis and subacromial bursa problems usually occur together because the subacromial bursa actually adheres to the underlying rotator cuff tendon. This is the Scapulocostal joint. Another name for this joint is the Scapulothoracic joint. The Scapulocostal joint involves the anterior surface of the scapula and the posterior lateral surface of the rib cage. Figure A shows elevation of the right scapula. Figure B shows depression of the right scapula. Figure C shows protraction of the right scapula. And Figure D shows retraction of the right scapula. These are the non-axial actions of the scapula. The left scapula is in anatomic position in all figures. This figure illustrates upward rotation of the right scapula at the Scapulocostal joint. The left scapula is in anatomic position of full downward rotation. The scapular action of upward rotation cannot be isolated. It must accompany humeral motion. In this case, the humerus is abducted at the shoulder joint. Upward rotation and downward rotation of the scapula occur within the frontal plane around an anterior-posterior axis. These figures illustrate tilt actions at the scapula. Lateral tilt of the right scapula is illustrated in Figure A, with the left scapula in anatomic position of downward tilt. Upward tilt of the right scapula is shown in Figure B, with the left scapula in anatomic position of medial tilt. Upward and downward tilt and lateral and medial tilt are accessory axial movements at the scapulocostal or scapulothoracic joint. The lay term for the lateral tilt is winging of the scapula. The scapulocostal joint is unusual in that it is not an anatomic joint because no actual motion of the scapula and the rib cage is formed by connective tissue. Primary movements at the scapulocostal joint include elevation, depression, protraction, retraction, and each of these can be created separately by themselves. The other actions must occur secondary to an action of the arm at the glenohumeral joint. This is a photo of the sternoclavicular joint that is located between the manubrium of the sternum and the medial end of the clavicle. The sternoclavicular joint actually permits motion in 3 planes about 3 axes, therefore it could also be classified as triaxial. But it is most often classified as biaxial because, similar to the saddle joint of the thumb, its rotation actions cannot be isolated. The sternoclavicular joint is the only osseous joint that connects the upper extremity to the axial skeleton. These major ligaments limit all motions of the clavicle except depression. The only ligament that limits depression is the costoclavicular ligament. The closed packed position of the sternoclavicular joint is full upward rotation of the clavicle. These are the average ranges of motion at the sternoclavicular joint. Elevation and depression occur within the frontal plane around an anterior-posterior axis. Protraction and retraction of the clavicle occur within the transverse plane around a vertical axis. Upward rotation and downward rotation of the clavicle occur within the sagittal plane around a mediolateral axis. Figure A depicts the elevation of the right clavicle at the sternoclavicular joint. Figure B shows depression of the right clavicle. Elevation and depression motions of the clavicle at the sternoclavicular joint are not oriented perfectly in the frontal plane. At rest, the clavicle is actually oriented approximately 20 degrees posterior to the frontal plane. Figure A illustrates protraction of the right clavicle at the sternoclavicular joint. Figure B shows retraction of the right clavicle. In this illustration, the left clavicle is in anatomic position, which is full downward rotation, and the right clavicle is in upward rotation at the sternoclavicular joint. Upward rotation of the clavicle cannot be isolated. In this figure, the arm is abducted at the shoulder joint, resulting in the scapula upwardly rotating, which results in upward rotation of the clavicle at the sternoclavicular joint. In this anterior view of the sternoclavicular joints, the right joint is shown in a frontal section. The left joint remains intact. It is stabilized by its fibrous capsule, anterior and posterior sternoclavicular ligaments, the interclavicular ligament, the costoclavicular ligament, and by the attachments of the sternocleidomastoid, sternohyoid, and sternothyroid muscles. The acromioclavicular joint, also known as the AC joint, involves the acromion process of the scapula and the lateral end of the clavicle. The scapula and clavicle would be forced to always move as a unit without the AC joint. The AC joint allows for independent motion between the scapula and the clavicle. The major actions that occur at the AC joint are upward rotation and downward rotation of the scapula at the AC joint. There are also accessory actions that occur. Lateral and medial tilt of the scapula and upward and downward tilt of the scapula also occur at the AC joint. When the scapula moves relative to the clavicle at the AC joint, it also moves relative to the rib cage at the Scapulocostal joint. These are the major ligaments of the AC joint. The AC joint does not allow a great degree of motion. Nonetheless, motion at the AC joint is necessary to allow motion between the clavicle and the scapula. In this regard, the AC joint is similar to the sacroiliac and pubic symphysis joints, in that these joints are located between the bones of the respective girdles and allow motion within the girdles. The AC joint is stabilized by its fibrous capsule, the AC ligament, and the coracoclavicular ligament. On this slide, you'll see the objectives for Lesson 9-2. Scapulohumeral rhythm is the coupled joint actions of the arm, scapula, and clavicle. Of all aspects of scapulohumeral rhythm, the most well-researched and published motion is frontal plane abduction of the arm. In each plane and in other coupled movements, the coupled action of the scapula facilitates further movements of the arm in the direction it is moving. The scapula usually begins to move before the arm moves as much as it can. From that point onward, motion is a combination of arm and shoulder girdle movements. Figure A illustrates a right arm that has been abducted relative to the trunk 180 degrees. Figure B shows that of the 180 degrees of abduction of the arm relative to the trunk, only 120 degrees of that motion is the result of abduction of the arm at the glenohumeral joint. The remaining 60 degrees of motion are a result of the scapula at the scapulocostal or scapulothoracic joint. The elbow joint is unusual in that there are 3 articulations enclosed within one joint capsule. This figure shows an anterior view of the right elbow joint complex. There are 3 articulations: the humeral joint, the humeral radial joint, and the proximal radioulnar joint. They are all enclosed within one joint capsule and share one joint cavity. Therefore, they can be considered anatomically to be one joint or one joint complex. However, because the 3 separate articulations are involved, physiologically they can be considered to be 3 separate joints. The proximal radioulnar joint is functionally separate from the elbow joint and will be included with the radioulnar joints. The humeral ulnar joint is functionally more important than the humeral radial joint. The humeral ulnar joint is located between the distal humerus and the proximal end of the ulna, and another name for it is the ulnotrochlear joint. The humeral radial joint is located between the distal end of the humerus and the proximal end of the radius. The humeral radial joint is also known as the radiocapitular joint because the radius articulates with the capitulum of the distal humerus. When motion occurs at the elbow joint, it occurs at these 2 joints. Because the elbow joint is a uniaxial hinge joint, it is quite stable and experiences few pathological injuries. The elbow joint allows flexion and extension of the forearm in the sagittal plane around a medial-lateral axis. Figure A shows flexion and Figure B shows extension. The average ranges of motion of the forearm at the elbow joint from anatomic position are 145 degrees of flexion and 0 degrees of extension. Figure A gives a medial view of the elbow joint capsule and the medial collateral ligament. There are 3 parts of the medial collateral ligament: the anterior part, posterior part, and the transverse part. Figure B demonstrates a lateral view of the elbow joint capsule, the lateral collateral ligament, and the annular ligament of the proximal radioulnar joint. The lateral collateral ligament has 2 parts, the annular fibers and the ulnar fibers. The major actions of the elbow joint are flexion and extension. The reverse action is that the arm can move relative to the forearm at the elbow. So some examples of this reverse action are pull-ups using a banister to go up the stairs, handicap bars, and using oars in a canoe. The closed pack position of the elbow joint is extension. The medial collateral ligament is also known as the ulnar collateral ligament. The lateral collateral ligament is also known as the radial collateral ligament. The carrying angle of the upper extremity is formed by the intersection of 2 lines, one through the long axis of the humerus and the other through the long axis of the ulna. The usual carrying angle is between 5 and 15 degrees, and it is formed because the axis of movement of the humeral ulnar joint is not horizontal. Another term for the carrying angle is the cubitus valgus. These are the 3 radioulnar joints. They are functionally related in that their combined movements allow pronation and supination of the forearm. However, they are anatomically distinct from each other. The proximal radioulnar joint shares its own joint capsule with the elbow joint. The distal radioulnar joint shares its joint capsule with the radiocarpal joint of the wrist joint complex. The proximal radioulnar joint and the distal radioulnar joint are both synovial pivot joints that are classified functionally as diarthrotic and uniaxial. The middle radioulnar joint is a syndesmosis fibrous joint and is functionally classified as uniaxial and amphiarthritic. During pronation and supination, the radius does the vast majority of the movement. Forearm pronation and supination are often measured from a neutral thumbs-up position. From this position, 85 degrees of supination and 75 degrees of pronation are possible. The proximal radioulnar joint is located between the head of the radius and the radial notch of the ulna. The middle radioulnar joint is located between the shafts of the radius and ulna. The distal radioulnar joint is located between the head of the ulna and the ulnar notch of the radius. Pronation and supination are joint actions created by a combination of motions at the proximal, middle, and distal radioulnar joints. Figure A illustrates pronation of the right forearm. Figure B shows supination. The ligamentous structures of the proximal radioulnar joint include the fibrous joint capsule and annular ligament. The interosseous membrane and oblique cord, which form the middle radioulnar joint, are illustrated in Figure A. The joint capsule of the distal radioulnar joint is also seen in Figure A, and the radioulnar disc of the distal radioulnar joint is illustrated in Figure B. The radioulnar disc is also known as the triangular fibrocartilage. This concludes the second lecture for Module 3.